Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
Hey everybody, welcome back to the Wild Health Podcast. I'm excited to have with me here today Dr. Mary Brittian Blankenship. Mary Brittian is a good friend. We've been friends for, 10 years now. Went to a residency together, was actually in the same residency program as her husband. She was an internal medicine resident at the University of Utah while Matt and I were there. And that's where we began our friendship. And then since then, Mary Brittian has, become somewhat of a mentor to me in the space of integrative medicine. And I think is probably responsible for my interest and my transition to how I'm currently practicing medicine. So Mary Brittian, thanks so much for being on the podcast.
Thanks for having me, guys.
We are throwing you a curveball today. I want to talk about a challenging condition that I think is challenging for multiple reasons. And I'll go ahead and say what I'm talking about. I'm talking about SIBO, or small intestinal bacterial overgrowth. And the reason I think it's challenging is because there's just so much talk about it out there and so much misunderstanding, I believe. And maybe that's just my personal opinion. Maybe that's not necessarily true. But I'm excited to have you on the podcast because I know I've gone to you in the past with challenging SIBO patients. And I'd love for you to come on and just talk with us a little bit about sort of maybe the basics of SIBO so we can understand it a little bit more as a group, as a community. So thank you very much for doing that. Maybe if we just start off first, though, and talk a little bit about sort of your transition from internal medicine to integrative medicine, because I think that's really interesting. And I'd just love to hear what got you first interested in integrative medicine in the first place.
Yeah, it's an interesting path for sure. So I trained in internal medicine, like you said, at the University of Utah, and I practiced as a hospitalist for 7 years. And it's challenging, it's interesting work, similar to emergency department in the sense that every day is different, and really treating patients at, the acute state. But I found that I was becoming increasingly frustrated because I was seeing these patients at their endpoint of disease. So heart failure patients, diabetics who were on dialysis with end-stage renal disease, patients admitted for massive heart attacks. And while I tried to provide some educational counseling to these patients while they were in the hospital, I found that I wasn't making a big impact because, I was seeing these patients come back over and over for repeat hospitalizations. And I realized that there was something missing in the educational part of medicine. And we as a society and medical community have shifted more towards this kind of reactive treatment. We get patients get sick, and then we do a lot of procedures or we give them a prescription, and there's not a lot of focus on preventative care. So I started doing some research and kind of had a vision of what my ideal practice would be like if I shifted out of inpatient medicine, and came across the field of integrative medicine, completed a fellowship through the Academy of Integrative Health and Medicine, and then have since opened my own practice, Spruce MD, Integrative Medicine here in Greenville, South Carolina. And it's incredibly rewarding to finally be on the other end and make an impactful change on patients' health before they develop these end-stage diseases.
That's great. Yeah, I mean, that sounds like a really familiar story in terms of frustration with the current medical system and treating the end stage of disease when there's so much preventative care that's being lost. So in your practice, Spruce MD, Greenville, South Carolina, you focus on integrative medicine. What does that mean exactly? What is, the focus of integrative medicine?
Yeah, so integrative medicine is interesting because it is kind of all-encompassing. So There is the conventional arm. So I do still prescribe prescriptive medications. I do still recommend conventional testing and procedures and screening tools. But then there's this whole other arm that is more in the alternative realm. And so there's a real focus on prevention in the sense of nutritional counseling and physical activity, and then assessment of sleep and stress, but also using medications and herbal supplements or vitamins in place of initially just handing over a prescriptive medication. And so it's really just a marriage of these two worlds. And so we do functional medicine, we do alternative practice, even some traditional medicine like Ayurveda, even maybe a little bit of Chinese medicine with integration with acupuncturists and chiropractors. And so it is this big kind of bubble of all types of medicine.
I like it. That sounds great. So you're focusing on the mind, you're focusing on the body, you're focusing on nutritional intake, and yet still managing chronic disease with in some cases pharmaceuticals or traditional means.
Right. It's a very personalized approach to medicine. And at Spruce, I function as many patients' primary care physicians. We have a lot of patients who come in for specific issues. And in that sense, I'm more of a consult or second opinion. But yeah, I have all the patients with cardiovascular disease and diabetes and elevated cholesterol, and we work to kind of reverse those diseases. But then I have patients who specifically come to me for gastrointestinal issues, thyroid disease, autoimmune disease, skin disorders. And so we have those healthy patients who just want to stay well. We have the athletes, we have those who are very into preventative health, but then those on the other end who are sick and who are looking to make some change.
Have you heard of this thing called SIBO?
Yes. Holy moly. I don't think I realized how much there was and how little I knew before I started my practice.
Uh-huh. Is SIBO one of those things, I guess? Because this is something that's not taught in traditional medical school or residency, or maybe it's just a brand new thing and we didn't learn it back then because it wasn't there. But is that one of these?
Yeah, it totally is, for sure. And just to provide some information, so SIBO, small intestine bacterial overgrowth, is actually what happens when there's an abnormal increase in the bacterial population in the small intestine. So these are particularly types of bacteria that are not commonly found in that part of the digestive tract. So these are bacteria that would be more commonly seen in the large intestine that have kind of overgrown into the small intestine. And they can be pathogenic or problematic when they are in large numbers. And so what happens is they ferment starches and fibers into gases, and that's when we start seeing patients become symptomatic from SIBO.
Yeah, that's great. So I guess one of my questions for you, Mary Brittian, is this really as prominent as it seems? I mean, it seems like so many people out there have these symptoms and are concerned that they have SIBO, and maybe that's because the symptoms are just so broad. I mean, it seems like anything that could potentially be abdominal bloating or distension or just mild discomfort could be diagnosed as SIBO. Is it really this prominent?
So the symptoms could be SIBO, certainly, but there are other things that can cause those symptoms for sure. I do think that it is underdiagnosed, and I think there's a lot more of it than we even realize. I think the latest statistic I saw said that there were 11.3% of our population globally has IBS, with SIBO causing 60 to 80% of IBS, or being the underlying cause, which is kind of astounding because A, I had never heard of SIBO until I did my fellowship. And B, that means if I didn't know, training in an allopathic medical program, like how many patients are undiagnosed? And so I think it is probably bigger than we realize. But yeah, all of those symptoms don't necessarily have to be SIBO.
And has something happened in society potentially to increase the amount of SIBO that we're seeing? Is this just because we're now giving a name to something that we previously called IBS? Is that the difference?
So partially. So I don't think all IBS is SIBO, but I think that IBS, while it's a real diagnosis, what I do in my practice, and I have a lot of patients who come to me with IBS, is we're always digging to find the root cause. And so when someone presents with IBS, we're looking for what the underlying cause of that IBS is. And I think SIBO a lot of times is that But I do think that SIBO is probably on our radar now, maybe because of the boom in the microbiome research. Integrative medicine and functional medicine providers have been treating it for some time, but I feel like I'm just now seeing gastroenterologists and primary care physicians becoming more aware of SIBO. I've had some patients come to me and they've had SIBO testing by their gastroenterologist, or their primary care physician knew of it, had no idea what to do with it, but at least it's on the radar. And then I think as a society, I think the number of cases have probably increased due to the frequent and overuse of medications like antibiotics, proton pump inhibitors. And then we already have altered gut flora just from our terrible Western diets.
So that's a good point. So I guess a good question now is, we understand SIBO can cause IBS, but what causes SIBO? You mentioned proton pump inhibitors, some antibiotics. Are these the most likely causes of SIBO in the first place?
So those are big causes. And typically when I'm evaluating a patient for potential SIBO, so if I'm concerned they might have it, those would be some of the questions I would ask. And so what happens is your small intestine typically keeps bacteria at optimal levels via motility and acid levels. So anything that's going to affect that motility or those acid levels is going to promote bacterial overgrowth. So things to typically think about and questions I ask my patients are, have you ever had a surgery before? Because we worry about slowed motility or structural anatomical changes from either a gastrointestinal surgery or even another surgery that's occurred in the abdomen and pelvis that potentially has resulted in adhesions or change the structural integrity of the gut. And then certainly ask about chronic or frequent antibiotic use, as that alters the gut flora, medications such as opioids, chronic PPI use, even antispasmodics, and then specific diseases. So thinking about like diabetes or scleroderma or lupus that can all slow gut motility. And then the big one that I find in a lot of my patients is food poisoning. So, if you ask a patient if they've had food poisoning, most people can say, oh yeah, it was terrible. I was in this country and this happened. And my symptoms, they actually began after that. And so that's a big one for a lot of my patients. But those are kind of the big categories that I touch on for patients if I'm suspicious.
So really it's motility and acid or motility and bacteria are the ways to think about it, right? Like the antibiotics or the antacids are going to be altering the bacteria that are present in the small intestines. And then motility sort of changes that I guess it's also changing the bacteria as well, but in a different mechanism where you're just not moving things as quickly through. So the growth can sort of come up, proximal towards the stomach, basically. Is that the concept?
Exactly. Yeah.
Okay, great. And that sounds like basically what you're describing is American lifestyle.
And it's so true. And I find, what's interesting with the antibiotic piece is that, it's so common for dermatologists or primary care physicians to put patients on just chronic low dose antibiotics for acne. Mm-hmm. And a lot of patients report that they've been on kind of this chronic antibiotic use for acne, and then 10 years down the road, they're presenting with these type of symptoms.
Like doxycycline, for example, for acne. Yeah. Okay. Interesting. Yeah. And then of course, all the prevalence of proton pump inhibitors. Do we see the same thing from H2 blockers as well, or is it more the PPIs?
It's more PPIs, actually.
Okay.
So the goal is always to get a patient off a PPI. And PPIs were developed for short-term use, 14 days max. And, but patients get stuck on them for years. I remember when I started as a hospitalist, or even in residency training, like when a patient was admitted to the hospital, you started them on a PPI for reflux prevention. And that, like, you had to, or you were dinged by insurance companies. And that's so crazy to think that we were once at that point.
Exactly. You might, if that's the goal, to get people off PPI, you might want to write a letter to, every gastroenterologist and primary care physician in the country. So. Great. What sort of clinical symptoms are we expecting here? So how are these patients presenting? I've seen such a wide range. What is the most common presentation that you see?
So patients will either present with diarrhea or constipation, or they could actually have a combination of both. They might have abdominal pain, cramping, flatulence or gas, nausea, fatigue. But I also see patients with reflux, and then they can even have extraintestinal symptoms. So they might have things that are a result of this increased intestinal permeability because of this altered gut microbiome. And so what I'll see is maybe cognitive issues, or patients will say, I just feel really foggy. Patients will have joint pain, skin disorders, specifically rosacea, and then, or eczema, and then like vertiginous symptoms. There's a whole slew of things that are seemingly unrelated that once you heal the gut and treat SIBO, they're like, oh man, like I'm sleeping better now, and my anxiety's better. And I think that is a result of this increased intestinal permeability that is, stepping back, initially caused by SIBO.
And that permeability, is that just leading to inflammation? Is that the cause of the strange mirage of symptoms?
Yeah, so the thought is, and most people have probably heard of leaky gut, which I feel like is kind of a terrible name, but that's the other name for it. But what happens is the tight junctions that are in your intestinal lumen are no longer tight. And so all this bacteria and metabolites and food substances that should be contained in the gut lumen are seeping out into your circulatory system. And so they're going everywhere in your body, in the sense that you are having these chemicals in every organ. And so you're having these symptoms that present that are not specifically GI. And that's also how or why we think that food sensitivities occur with this increased intestinal permeability.
So tell me about your approach to this. Are you clinically diagnosing this? Are you looking for evidence of leaky gut? Are you doing breath tests? What's your approach?
So first, a good history. So certainly most patients are presenting with IBS type symptoms, but not every patient with IBS type symptoms has SIBO, nor do I run a SIBO test on them. And so I'm asking all of these questions that we kind of talked about before about their history and their medication exposure, et cetera. And then if I'm suspicious, then I will do a breath test. So there are different breath tests that are available, and these can be performed in physicians' offices. Typically, gastroenterologists will do them if they are treating SIBO, but there are also take-home breath tests. And these are either 2 or 3 hour tests that can be done at home. And there are different substrates that are used with these tests. So there are lactulose breath tests and there are glucose breath tests. With the lactulose, the benefit is that you're going to get farther into the small intestine. And so you're going to be able to look at more distal SIBO. So with glucose, you're really only absorbing it in the first 3 feet of the small intestine. So you're not diagnosing this distal SIBO in the latter, like 17 feet of the small intestine. I typically do lactulose breath test, and I typically do a 3 hour test because I want to look at as much data and information as I can. And I think that even with the test and with the diagnostic criteria, you have to use, your physician brain and your clinical acumen to really make the diagnosis. Because if someone has constipation, you're going to really want to look at that 3 hour mark versus someone who has a faster transit, because you're going to get an expected rise in these gas producing levels in the large intestine that you wouldn't expect to see in the small intestine. So you could be looking at the large intestine if you wait too long with someone with a fast transit.
Yeah, these tests don't really come back with just a yes or a no. It's not like a simple blood test, right? I mean, you're getting a graph with different gases on it, and so and it's looking at different gases too, right? It's not just single things. So what is it looking at exactly?
Yeah, so what the tests are measuring is the production of hydrogen and the production of methane over the course of this 2 or 3 hour test. And so the clinical diagnostic levels, and these were established, and I think there was an article in the American Journal of Gastroenterology in 2017 basically establishing these criteria. And for the hydrogen producers, there needs to be a change of 20 parts per million over 90 minutes. And then with methane, if you see a level of 10 at any point during the test, that's diagnostic. There is a third gas, and it's not tested for, and that's hydrogen sulfide. There's no test currently to test for hydrogen sulfide, but a lot of practitioners will consider that it's diagnostic if your test comes back completely zeroed out, because you don't typically see that, and if patients are symptomatic. So that's kind of a newer thing with a lot of research going on right now.
So basically, just to break it down, so the patient ingests lactulose. That lactulose goes through their stomach into their small intestines. It produces, based on the amount of bacteria in their small intestines, either hydrogen or methane, or potentially both, depending on the combination of bacteria. And then you see that rise in gas when they're doing this breath test, right? But the complicating factor being that you can also see an increase in these gases once those chemicals get down into the large intestines as well, correct?
Yeah, that's correct.
Okay, so not exactly straightforward, but at least we've got criteria now, which we didn't prior to 2017, about the actual numbers and what truly is SIBO and isn't SIBO, based on at least some diagnostic criteria, right?
Yeah, correct.
Okay, all right. So
say the actual gold standard would be to truly aspirate the jejunum,
right.
But I mean that's subjecting a patient to endoscopy, and then it's hard to actually get to the jejunum with an endoscope. And so, you're essentially, for most patients, probably sampling the duodenum.
Right.
So that test is not the best test, but it's what we've got right now. And it definitely requires not just a straightforward look at the test.
So speaking to that, do you ever choose to just try treatments with patients, or do you ever get negative breath tests and then still try treatment just because the clinical presentation is so suggestive?
I typically don't. So I don't like to treat without having some data, because if they're not getting better and we do a test afterwards, how do we know where we started? And I think it's also helpful for patients to know that they have a definitive diagnosis, and that they can see that there has been some improvement of their levels post-treatment. I will say that when we start a protocol, once we know we have a diagnosis, we'll evaluate after initial treatment and decide if we need to retreat. I don't always check again after the first round of treatment, because oftentimes it does take more than one round.
Right. Right. And speaking of rounds, what are you using? Do you start everyone off at the same way? Always go with diet first, then supplements, then antibiotics? What's your approach to treatment?
So there are typically 3 arms of treatment that I will offer patients, and it's personalized medicine, so patients have a say-so in what their preference is. So antibiotics are the typical conventional treatment arm, and then there are also herbal antimicrobials. And there was a meta-analysis in Global Advances in Health and Medicine in 2014 that showed that herbal antimicrobials are as effective as antibiotics. So herbal antimicrobials can be used. And then the third arm is an elemental diet. And that basically is a pre-digested formulation that patients can substitute for meals. It provides all their caloric and nutritional needs, but the gut doesn't have to do any work. So definitely the hardest arm, and I would say I have very few patients choose that. So a lot of times we'll offer this hybrid treatment model where we'll do some elemental in combination with antibiotics and herbal antimicrobials.
So you'll do a little, like all 3, basically.
Sorry, not all 3.
Oh.
Either elemental diet with antibiotics or elemental diet with herbal antimicrobials.
Oh, okay. All right. And then the herbal antimicrobials, everyone's going to write us and ask us this question. Is there a specific one that you use? Are there things that you're looking for in your concoction?
Yeah, so specific herbs you're looking for: berberine, allicin, neem, oil of oregano. And then there are specific herbs for whether you are a hydrogen producer or whether you are a methane producer. And so it's definitely dependent upon what your gas levels show. And so the combination of herbs may be different for someone who has a high methane level as opposed to hydrogen.
Gotcha. Yeah, and you can pretty much go on Google and find about 300 different companies that are making a different herbal concoction for this. So lots of options out there. What about antibiotics? Is there a specific one that you lean to?
So rifaximin is the go-to. It is best for hydrogen producing bacteria. And then I typically do neomycin for methane producers. Certainly there are other antibiotics that are used, Flagyl, Cipro, Bactrim. I just feel like a lot of those have more side effects. The problem is rifaximin is ridiculously expensive, and it's not approved for SIBO. I think there is now approval for IBS diarrhea type, but not specifically for SIBO. So you can code it so that patients can get reimbursed, but I do a lot of prior authorization to try to get approval because it can be very expensive.
That's so interesting. It's like the go-to antibiotic for SIBO, yet it's not approved by the FDA for whatever reason. Yeah.
And it's because there's not a generic, even though
Right.
it's been around forever.
Well, there just hasn't really been much of a use for it, I think. So people haven't really bothered to. It's not a very
Yeah.
popular
I mean,
antibiotic for other.
uses for prevention of hepatic encephalopathy and like end-stage liver disease. So, yeah.
So do you get concerned about protecting the microbiome when it comes to using these antibiotics? I mean, we're going to, and to some degree, it's kind of like a shotgun approach, right? I mean, you're just going to destroy all the bacteria in the gut.
It's true. And I think that's a really hard part. But then you see these patients who have suffered for so long, and some of my patients for decades. And so I typically don't recommend using probiotics during treatment. And actually, I find that a lot of patients with SIBO can't even tolerate probiotics. So they'll come in and they'll say, I try to take probiotics because I thought that might help for whatever symptoms they're presenting with, whether it be diarrhea or bloating. And they say it just makes it worse. And so you think it's just feeding the bacteria, so adding more bacteria. And so what I typically do is treat and then work to restore the gut microbiome and add probiotics and amino acids and those things to kind of restore that mucosal lining. There are a couple of probiotics that have received a bit more focus recently, specifically Lactobacillus reuteri and Lactobacillus rhamnosus. And so those as single bacteria, and you can get them as probiotics with single bacteria, sometimes are used for patients during treatment. And the thought with those is that they're both resistant to several antibiotics and they have a pH that's pretty low, so they survive passage through the stomach. And so that's the thought of why those might be beneficial during the treatment phase of SIBO.
Oh, interesting. What about diet? So you talk about the elemental diet, and you mentioned it's sort of this like pre-digested liquid, right? I mean, that's basically what it is. Yeah. It's just like a drink. Is there anything specific to it other than that? Is it just like the basic building blocks with some vitamins and minerals? Is it really something you have to buy? Can you make it at home? I have so many questions.
Right. So it's a powder, and you add it to water, and when you are consuming that every meal for 3 weeks, it's tough. But yeah, it basically is just basic vitamins, minerals, calories, and you can make it at home. It's pretty complicated. I have looked at a recipe before, and I don't even know where you would find all the ingredients. The Integrative Therapeutics makes it here in the States, and so typically that's where patients purchase it from. But it can be pretty expensive as well. So that's a treatment arm. But when we're talking about diet with SIBO, there are differing camps on recommendations for SIBO treatment. So when we talk about diet, a lot of practitioners will put patients on the low FODMAP diet. And FODMAP basically stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So you're basically limiting all these short chain carbohydrates and sugar alcohols that are poorly absorbed by the body. And these carbohydrates and sugars serve for food for these bacteria. So that's what causes this gas production and these symptoms. And so the thought is if you're limiting these high FODMAP foods, you're already kind of decreasing this bacteria number and potentially leading to some die-off before even starting therapy or during protocol and treatment. And then there's another camp that puts patients on the specific carbohydrate diet, which is a grain-free diet, low in sugar and lactose. And then there's a whole other group of practitioners that recommend against any dietary changes with the argument that the bacteria should be fed during the treatment process to get the most die-off. So, my stance has changed over the course of treatment, but there are different options. And I think that honestly, like they all must work if different practitioners are getting good outcomes from all of these different options. So I typically push a lower FODMAP diet in the sense that I present what the highest FODMAP foods are and ask them to limit those in their diet instead of just a very strict FODMAP diet.
Yeah, I mean, just as sort of a interested observer, I've seen people, who are fairly symptomatic go on a low FODMAP diet, mostly because it decreases their symptoms. And then over the course of years, it seems that their symptoms kind of die off and they get back to a more normal sort of diet, which I suspect is just sort of a long, slow progression of change in bacterial overgrowth in their small intestines. But I have no data to support that. But it does make sense that, you feed them less and they're going to grow less, right?
Yeah, for sure. And it definitely improves patients' symptoms when you put them on a lower FODMAP diet.
Yeah. Have you actually tried this elemental powder stuff?
I have.
Yeah.
It's pretty grainy.
Grainy. Someone described it to me one time as like warm urine. And then you immediately ask the person, why do they know what warm urine tastes like?
That's disgusting.
Yeah, not
Yeah,
bad.
no, my patients who have chosen to do that in its entirety are rock stars. Like, I honestly am not sure how they go the full duration on that alone.
And that's, yeah, and they've successfully done it and eradicated the SIBO. Is that true?
Yeah, I find that my best outcomes are with those patients who do elemental only, or if they do a combo with elemental and another treatment. But yeah, it's intense.
You ever use any fasting in your protocols to try to just get, like, I guess, time away from food for the small intestine?
I do, for sure. So that's part of our recommendation with treatment as well, is to space out meals. So doing 4 or 5 hours between meals, but then a very specific overnight fast, even if it's just 12, 13 hours. And the thought behind that is that the migrating motor complex is what drives a lot of this and prevents this bacteria from being cleared from the small intestine. And so when you provide this period of fasting, the migrating motor complex can really kick in. And when it's most active is during the periods between meals. So it kind of plays a housekeeping role and just sweeps out this residual undigested material.
Awesome. Well, I think that's all the questions that I have, Mary Brittian. Do you have anything else that you'd like to share about SIBO?
So interestingly, I will say there are a few diseases that we see direct relationship with SIBO. So if I have a patient who comes in with rosacea, I start immediately asking gastrointestinal symptoms because there's a relationship there, along with like celiac disease, which is not super surprising, thyroid disease, specifically Hashimoto's, and then inflammatory bowel disease. So when patients present with those, SIBO is always on the radar.
Interesting. It's a good thing to keep in mind when you see those diseases
Yeah.
present, because not everybody has the same degree of symptoms with SIBO too, right? Some people, are just really, really messed up by it and can barely live their lives, and other people, it's really just a minor issue. So cool. Well, thank you very much, Mary Brittian. This has been great. I really appreciate you coming on the podcast. We'll have to have you back sometime soon for another topic that you can educate us about.
Thanks for having me.
Thanks for listening to the Wild Health Podcast. If you found it helpful, give us a 5-star rating and write a review on iTunes. It really helps the podcast, and we greatly appreciate it. If you want to be a client or you want to work with us, go to wildhealth.com. Thanks again.